Welcome everyone who's joining. I'm going to wait for the attendees to come in, so I'll just give it a minute or two. All right, the attendees are coming in, and I see that number slowing down, so I think we can go ahead and start the webinar. Hi, Amber, how are you?
Hi, sorry, I didn't mean to give you a heart attack. We were in a meeting up until like a minute ago. So you're probably like, are they showing up? But I have Tash and Maeve with me, and I think we're just going to share this screen. You guys aren't going to sign. Are you going to sign on too? Probably not. Would you want all of our faces, or do you want us to rotate in the screen? Do you have a preference?
I think rotating's fine. Yeah. Okay. Well, I'll give you a few minutes to catch your breath, and by giving some a long introduction here. Welcome to all the participants on the webinar. Yeah, and welcome Maeve and Tosh. This webinar is titled Crisis Outreach Response and Engagement, a model for incident de-escalation and a shift in public safety's culture. And before I provide some introductions to our three speakers today, just a little bit of housekeeping. First of all, as a participant, you are muted. So if you have questions or comments, you can enter them anytime in the Q&A chat, and others can see that and contribute to that. So you're welcome to do that. And then I also want to make sure to announce our next month's webinar. For the first time ever, we're going to feature a student panel. It's called The Future of Injury and Violence Prevention, Injury Center Student Research Projects. So that's going to be May 12th at this same time. And we have recently created a student research grant program, and we're going to have our first 3 recipients of that present on their work. And they've had their awards for about a year now. And it's students from the CU Anschutz School of Medicine and the University of New Mexico. So that's for May. And now let me turn to this month. We have 3 speakers, and I'll just provide short bios about each of you, perhaps not in the order that you're speaking. First, Tosh Petsas. Did I say your name correctly? Oh, close enough.
Petsas.
Oh, Petsas. Thank you. Who's a master police officer with Longmont Department of Safety. He began his career in law enforcement in the city of Leadville in 1997. And in 2004, became a master police officer. He's worked for the Patrol Division, Beat Support Team, Gang and Crime Suppression Unit, and the CORE team, which is the focus of today, the Crisis Outreach Response and Engagement team. He strives to build relationships with community members he interacts with, as well as finding outside of the box solutions. Also with us today is Maeve Widman, who's a clinician with the CORE, the Crisis Outreach Response and Engagement team within the Longmont Department of Public Safety. She's responsible for offering clinical crisis intervention services, mental health evaluations, and service coordination with her CORE partners to the Longmont community. Prior to her role, Ms. Widman has spent many years working in community and inpatient psychiatric facilities. And then third, we have Amber McDonald, who is the Deputy Director and Assistant Professor for the Stress, Trauma Research, Trauma and Adversity Clinic, the START Clinic at the CU School of Medicine in the Department of Psychiatry. Dr. McDonald has created, developed, and sustained successful multidisciplinary teams, and she provides investigative case consultation, training, and support for law enforcement, district attorneys, and other investigative parties regarding criminal cases involving major crimes. So I am pleased to welcome the 3 presenters today, and at this point, I will turn it over to Amber.
Hi, everyone. I assume that not everybody who's in the webinar is on screen, or we can't see.
That's correct. There are currently 29 participants in total. Only the panelists are visible, and we'll turn off our camera as you present.
Wonderful. So hi, everyone. Welcome. We're so excited to share with you our program today. Maeve and Tash, who are part of the team who does the work day to day, are going to do most of the presentation. I will come in at the end and talk to you a little bit about some of the evaluation that we're doing, which is really exciting. I provide all the clinical oversight for this team, as well as the other teams that they'll talk about a little bit later. Just wanting to start, can everybody see my screen?
That looks great.
Okay, wonderful. Well, this is Omar. He's not a part of this presentation, but he is our paramedic extraordinaire. And we'll go ahead and get started. So all you have to do is hit the arrow button.
Yeah. So CORE was originally created as a diversion program. So one of our #1 goals is to keep people out of emergency rooms and out of the jails as much as possible. And that's kind of why we created the team that we do have. That's why we have police officers. That's why we have medics. That's why we have clinicians. So we can kind of bring all that expertise to people in the moment. Within our diversion programs in the city, we have kind of 4 branches of it. So we have our law enforcement assisted diversion. That is a case management team where patrol can refer people directly in to kind of try to divert criminal charges and get people some help as far as substance use goes. They function off of a harm reduction model. So it's definitely a meet people where they're at and work with them to kind of meet the goals that the individual sets themselves. The second category over is going to be us. So that's our crisis outreach, response, and engagement. Like I said, we have police officers, we have paramedics, we have clinicians, and we all work on the core team for 40 hours a week. It is our primary assignment. Our officers are all selected and have gone through specialized trainings and stuff like that to be able to do this team 40 hours a week, and same with our medics. They're not connected to the fire department or anything like that. We are all city employees within this team. Because we have paramedics and police officers along with clinicians, we are a primary response model. So there's kind of 2 different versions of co-response teams. There's some that patrol officers will go and then call them out there once the scene is totally secure. People are generally de-escalated, and those co-response teams will come in and do their magical work there. Because we are primary response, we can respond to all of those active calls. So suicides in progress we can go to. We've gone to disturbances that are still escalated. Sometimes we're first on scene to those. It just kind of allows us to respond to the crisis in the moment and not a couple minutes after, once things are calmed down and stuff like that. So I also think it helps us get a more fair assessment of what's going on in the moment from all 3 perspectives, instead of once things have chilled out a little bit.
Where we probably should have started by sharing, and that was my misstep, is that so the core team, which is what we're talking about today, is a part of a Department of Public Safety. So Longmont is one of the few agencies across the country where police and fire are together in a Department of Public Safety. So they don't have separate chiefs, as opposed to finding a police station or a fire station or department. And so the programs that Maeve is talking to you about this afternoon are all housed under public safety. And so these are, as Maeve talks about, the diversion program of LEAD and case management, and then CORE, and then she'll continue to talk about the Angel Initiative and community health. Keep in mind that is within the Department of Public Safety within the city of Longmont.
Yep. So kind of going back to some of CORE's main responsibilities, we respond to those calls for service as they're coming out. But kind of a big part of what our team does, probably most of the days, is follow up with all the people that we have previously contacted. So if we contact someone who is suicidal, whether we place them on a hold or not in that moment, we strive to contact them again within 72 hours, make sure that the skills we provided are effective, that they're working for them. If not, we can reevaluate that. The resources that we provided are effective, they're what they're looking for. And really just kind of create that human-to-human contact and connection to be more than just a one-off. We see you on your worst day. We want to see you on all the days.
And we strive to do those follow-ups in person. we want to get out there and see them again in person, build that relationship. Yeah.
So overall, CORE is really similar with LEAD, is a community response model housed within a public safety. We really treat this team. We've developed our own mission and vision in order to dictate how we engage with folks. And as Tash mentioned, getting out to see people as a team that wants to be viewed as a community resource, being in the community. So in addition to responding to behavioral health calls for service, they are out in the community introducing themselves to organizations as well as businesses, so people know that there's an alternative response when there are behavioral health crises. So we'll continue to move on and break down some of these to give you some more details of what these look like, these additional teams. The Angel Initiative is also a diversion program in terms of folks on some level, right, where they can be filtered into LEAD.
Yeah, well, Angel Initiative, they can just, anybody can walk into the police department at any time and just ask for help, and they will get a case manager to find a program that'll work for them in terms of recovery. And they try to make it meet that person. So they don't just have one program they go to, they seek what's going to work for the individual financially and in their beliefs and what they need.
And that is an option also if people pick up summons or something for substances as well, correct?
Not so much, but
Okay.
they can, if they come in, they can do that. That's a total, it's all on the individual to do Angel.
Okay,
It's
to be able
not
to
a-
ask about that.
Yeah.
Okay, and then we'll cover community health here in a little bit, but that's essentially, this slide is really covering the 4 kind of community health and resilience programs that the Department of Public Safety has. So go ahead.
So we on scene, we've got the shared responsibility for the M1s. Everybody on the team can write an M1, can assess for that. We all provide de-escalation. We all can do hands-on stuff. Maeve is trained in, is it CPI?
Yep, CPI. And we also did defensive tactics through the police department.
And then, we work hard to break down these barriers and perceptions with the mentally ill and their interactions with police. We've had some really good outcomes with people who historically have had a lot of problems with the police. And now they actually have really good interactions, not only with our team, but also with patrol. And then the high utilizers, we try to dig in and find out why they call so much and how we can help them and work through that. Rather than just continue to go back, we'll try different approaches or different ways of dealing with them. And then we've got the 3 different professions on scene. So we each are subject matter experts in our own categories and can really communicate on scene what's going to be best, because while what I view in my law enforcement perspective might be the best, it may not be the best medically or psychiatrically. So really coming up with a good solution for this person or a way to help them. And then those follow-ups, we're trying to find resources that are going to work for the person if they want them. Some people don't want anything at all, and we'll continue to visit with them as they generate calls and see if they want help and try to motivate them to find a better place. It helps out patrol because they're not having to deal with the mental health calls, because there's a lot of them that come in, and it can be really stressful for officers because there's essentially nothing they can really do, and they've got another call pending, but they don't have the time to spend on scene with that person. Whereas the core team, we can come out and we can take as long as we need on scene. We had one team drive a person all the way up to Wyoming because that was going to be the best for that individual. So really thinking about other options and what we can do outside of the box truly helps patrol, because that person will hopefully not need to call patrol as much or generate as many calls. So patrol doesn't have to deal with those either. If that makes sense. Sorry, I'm rambling.
As you know, I'm sure many of you have heard politically in terms of the role of law enforcement in behavioral health. And we kind of take the stance that law enforcement will never be out of behavioral health. People are trained from the moment they show up in this world to call 911. And so being able to equip specially trained officers with clinicians and paramedics then removes the job for patrol and having to manage, which is exactly what Tash is talking about here. And Maeve mentioned earlier in terms of, we don't just get kind of whoever in patrol, we have specialized officers who apply for this job. The additional component is, and while we don't have great data, between 20 and 60% is what's in the empirical data about how many calls for service patrol deals with involving mental health, behavioral health, or substance use or abuse. And so we're always, as well as many teams across the nation, are trying to figure out what constitutes what we would call a core call. Right now, it usually has to do with kind of suicidality, or anybody in law enforcement terms, they would mark it a code 6, or somebody that we know we will go out even if it is not a behavioral health call for service.
So some of our biggest goals is we want to bring the right resources to the right people at the right time. That's one of our biggest goals. That's kind of why we decided to have 3 professions on this team. Because we never know what's going to be most effective, what someone's going to need in that moment. We really want to make sure that we can provide the support where the crisis occurs. Again, kind of doing a secondary response is not, at least in our eyes, what is most effective, because we want to meet people where they're at. If they're struggling on the street or in a gas station or at their house, we want to be able to meet them there and kind of work through that. And we also respond to all ages. So when we go on calls with geriatric patients, we've gone on calls, we've done a whole lot of work with kids and really, really young kids. I think we have some clients in our database that are 2 years old and we're still doing work with that type of stuff. So we really kind of stretch to the whole lifespan of mental health, stress, how that all shows up. Like I said earlier, we really want to decrease the use of ERs and jails for mental health emergencies. We've kind of created a lot of connections with some of the local mental health hospitals, so we can do direct admits there. And because we have a medic on scene, they can do the medical clearance there, completely skip the ER and the 6 to 14 hours someone's going to wait there for that medical clearance and that psych assessment. We can do that all in the field because we have officers, we have secure transport, so we're able to drive people to where they need to go. We've taken people to Denver Health, Children's Hospital. We go to Centennial Peaks, we go up to North Range, we go to Johnstown Heights. So we really utilize all of the resources we possibly can that are going to meet that crisis in the moment.
We have relationships with the jail as well. So we can reach out to the jail when we know somebody's coming in and encourage them to have them re-engage with either lead or the core team. So we can hopefully help them have better outcomes as well.
So one of the things that has been historically common is that when law enforcement, who have always been able to place somebody on an M1 hold, and that is when somebody is gravely disabled or is a threat to themselves or others through suicidality or homicidality, is that they get kind of booted right back out the door. And so one of the benefits of a team like this is that with this trifecta professional, they can assess and more appropriately bring folks to the hospital as opposed to taking up time that might not meet criteria for that higher level. And as Maeve said, us being able to direct admit allows us to skip over. And we have a every other month meeting with our hospitals and community behavioral health to continue collaboration and also problem solve some of our high utilizers who may struggle with addiction or cycle through episodes of mental health concerns as we try to stabilize folks. So that's part of this role as well.
So what we do is, we've got the 3 disciplines, and we go to calls involving mental health, substance use. We went to a medical call yesterday that an officer felt was a mental health call, but it truly was a medical call, and our paramedic was able to identify that and get the gentleman to the hospital. We're there right away, so we're able to start de-escalation and take that time to do it. And as we're there with the person, start working on what's going to be the best for them. What are the best resources? Ideally, we want to leave somebody at home and have them enjoy their home life. But sometimes we have to go other places, and that's okay. And we work with that individual to share the plan. They're a part of the plan. We're triaging and assessing the individual. And then the clinicians are great at giving skills to help the person manage their life in the moment and assure the person that we're going to follow up with them and make sure that those systems are working and what they need. And then obviously we have a lot of different options, whether it's taking them to walk-in center, a direct transport to a psych hospital, diversion from the M1, where a patrol officer normally is like, oh my gosh, this is an M1. I got to take them right now. They have to go. And we have those. And we step in and explain, no, this is okay. They can stay home. They're safe here. We've got a plan and they're going to be all right. And that relieves patrol too, to know that, oh, okay, we don't have to take this person's rights away and take them to a hospital. And diverting them from the jail. Often a lot of officers seek us out and say, hey, what's going on with this person? Is this mental illness or is this something else, or what do we need to do? So we have a good relationship with patrol in that too. And we're always looking for that appropriate resource for the person. And in our follow-ups, we make sure that research or that the resource actually worked, because we can give them a resource and walk away and never talk to them again. And we don't know if it worked for them or not. And then if it didn't work, they're still struggling. So how can we make sure that we get them the right resource?
So as far as our team goes, like I said, we really want to attack it from all angles. So we have 3 officers, we have 3 clinicians, and we just made an offer for a 3rd medic. I'm Mavis Tash. Omar was the guy on the front screen. But yeah, kind of a really big part of this is we have so many different avenues of de-escalation to attack this complex problem. Our medics can,
Sorry.
gosh, our medics can do some pretty amazing work. If someone is like, I'm not mentally ill, I don't need the police, our medics have a really good in with that of like, well, something's going on, let's just check you out. Let's grab your, blood pressure, let's get your vital signs, see that. They're able to kind of dig into a lot of the history that if, a clinician or a police officer asks, tell me about, have you ever been arrested? Like, what does your mental health history look like? Versus a medic asking, have you ever been to the hospital? They can get a lot deeper into some of this stuff where someone might shut down to me or Tash. The other side of that, some people are absolutely having a mental health crisis, and we all recognize that, but they want that officer and they feel, safe around that officer and like they're the one who can handle it. And all of our officers and medics have fantastic de-escalation skills that can all attack this problem just as much as the clinicians do.
That's one of the unique roles of our team, is that everybody gets clinical oversight as opposed to just the clinicians on this team. For exactly Maeve's point, is that sometimes folks don't want anything to do with clinicians because they have a historical view of back when psychiatric hospitals kind of strapped you to boards and put you in rubber rooms, and vice versa. I think our law enforcement officers are routinely doing crisis intervention long before these teams showed up. And so they have exceptional skills in some of these areas, and then we get to pick the best of the best to join this team. And so one of the supervision approaches that I take, we also have a sergeant that he and I co-lead this team, is that the team should not agree all the time, because if they did, they wouldn't be necessarily adhering to their own expertise and discipline. And so we work through complex problem solving even among ourselves as we think about what is the best approach for this individual.
There's pictures of everybody.
So you can see everybody on this team, and once we get the Sergeant Andy Feaster's right here, that's my partner, and once we get the okay for our additional medic. So right now, everybody is actually employees of the Department of Public Safety. That has mitigated lots of issues related to HIPAA and information sharing. And so at one point we had a partnership with UC Health where Alexa, as you'll see on here, and our paramedic Kyle worked there. So we actually had Epic access. UC Health actually sponsors a number of co-response teams across the state, but we eventually got the city to kind of buy out those positions. And so now they're city employees. So everybody goes through backgrounds and does all the process that law enforcement does.
And then back to all those spaces, I think something important too is we all sit in the same room. We're not separated, so we can talk to each other about cases. So even if officers or clinicians weren't on scene, they can be present in the conversations. So we can work through things and use everybody's expertise to help resolve issues.
Want to go through this one?
Sure. So these are kind of our split responsibilities. As you can see, a lot of them are across the board. I mean, navigate resources, everyone does. De-escalation, everybody does. But then we kind of break it down into our individual specialties. So, I mean, the officers have that scene safety unlock. They let us know, when we can get closer, when we should back up, all that kind of stuff. Things that, my clinician mind is not typically thinking of. I want to get close. I want to build that connection like physically. And sometimes we have officers be like, ooh, like, let's take a step back. We can still build this connection, but we still need to be safe. All of our officers can evaluate for mental health holds. All of our paramedics can, and so can all of our clinicians. So that's another one that's kind of across the board. We all engage our clinicians. We do kind of a risk and clinical assessment to see, can we leave this person home? What does that look like? And kind of work through all that type of stuff. And then we can also recommend placements. So again, my background is in inpatient mental health, so I very much understand what the reality of hospitalizing someone looks like. And our other two clinicians, they have both worked in child welfare, so they very much understand those systems and what does those referrals look like and what do those reports look like and what's the expected possible outcomes of all that type of stuff. Our medics do an amazing job of navigating the ERs and calling and giving that medical report and letting them know all the medical stuff they've already done on scene. The call yesterday Tash was talking about, I think our medic hopped in the back of the ambulance and took the call for the other paramedics who arrived on scene, and he was able to continue that care all the way through this person's transport. They're on scene, all that kind of stuff. And our medics are able to kind of step up and notice those things that we might not know about. In this year, we learned that UTIs can absolutely be a cause of psychosis. We ran into someone who had just a crazy thyroid issue, and that was causing her to be incredibly psychotic. And it was something our medics were able to recognize and, kind of help make a plan for this person of, yes, they need to be in a hospital, but a medical hospital, not a psychiatric one, because this is a medical issue when it comes to the root of it.
And when we're going to go to a psychiatric hospital directly rather than go to the emergency room, the paramedics do the medical clearance, so they're able to determine if it's safe for them to go to that psychiatric hospital. And actually, yesterday, our medic said that an individual could not, based on their medical history and what he was seeing.
And anybody who's familiar with co-response teams have actually been cutting medics across the nation, and we fight really hard for ours. They certainly go through different training than regular medics with this team, where sometimes we have them provide the information about the physiological manifestation of trauma, right? And so while behavioral health and even law enforcement can talk about how trauma manifests in the body, really that hard scientist, as opposed to the soft scientist, really can offer that. And that's really how we see their role. And Maeve talked a little bit earlier. We had a call that we went out on where there were concerns of behavioral health, but she had actually had been part of a situation where people were being abused in a mental health facility. She wanted nothing to do with me, and we tried the approach of getting in through concerns around diabetes. So it gives us some flexibility depending on who that person is relating to in that moment. I think that's it.
So, again, the follow-ups, I think that's really where the backbone of this program is, because we can all go out and de-escalate, but if there's no follow-up to get that person connected or make them understand that they're a part of the community and welcome to the community, I don't think we're going to have success or anything moving forward. And then we outreach people that we see in the community, people that we see struggling. We'll stop and talk to them, or people that we know that we've interacted with. We'll stop and check in on them when we just see them out and about. We check in with the community, so service providers, businesses. We let them know what we're about and what we do. We do presentations like this to let other people out there know what we're doing and how we do it.
So Julie, that's a great question. And we're still formulating that. We're working with dispatch to kind of code some of the data in terms of what is a core call. The luxury of having a law enforcement officer on the team is that we can actually safely respond to any call for service. But as we mentioned earlier, kind of our package, right? If it's a behavioral health call for service, or sometimes patrol will be out because it was dispatched as domestic or something along those lines, and they realize when they get there that it is more about behavioral health, or vice versa. And what will happen is we'll kind of kick them to each other, or core will come to the scene, release patrol back into service. We just did a really great job of operationalizing what a core call is and what you get, like what's the package. And so you get a call for service, and we have committed to doing at least 2 follow-ups afterwards. So here in a little bit, I will talk to you about some of the data that we're collecting in the empirical program eval we did. And as Tash just said, the biggest change is in the follow-up, and that's what people really care about. And it makes sense. Anybody who knows anything about crises knows that when people are that dysregulated, they don't remember a whole lot from that initial intervention. But being able to come back and follow up, scaffolding skills to them, getting them connected to where they need to be is the meat of this programming.
And we also have the ability to self-dispatch. So a lot of times we'll just be listening to the radio and hear calls that we think we can help out on. We'll go to those. And we'll kind of respond in our way. Dispatch has done an amazing job of recommending us to people who are in crisis in the community. We've gotten a lot of calls that request core specifically, and we have never met this person. We've never been to their neighborhood. We have no idea who they are. When we ask them, like, how did you know about us? They tell us, oh, I described what was going on, and dispatch recommended this response. And then a lot of our other kind of calls come from this outreach with community, with organizations, getting our name and what exactly we do out there. We've had King Supers call and ask for core specifically because they, believe what's going on is mental health, and we've made it a point to go in and chat with the managers and be like, this is what we do, this is what we are. And just businesses like that are able to request us specifically.
And when we're not available, our patrol officers will send us emails or leave us voicemails or write a note on a napkin and ask us to go help somebody. So we also have that steady stream coming in as well from our patrol officers.
One of my favorite things, and what we actually learned about in the data, is this team gives out also like gifts, right? So I do a considerable amount of private practice as part of my faculty appointment. And we use workbooks. And so we give those to folks, especially if they're trying to connect. We give them maybe the bracelet that you're wearing. We give them bracelets about like somebody cares about you. We give fidgets. We give all of these kind of regulation tools as part of us being in the field. One thing that we probably should have said earlier is we are not staffed 24/7, but Monday through Friday, we're staffed from 8 a.m. to 8 p.m. And on Saturday and Sunday, it's 9 a.m. to 6 p.m. And that is dictated by data in terms of when behavioral health calls for service come in. Now, certainly we get feedback as nobody can plan for their crisis within those hours. So the new chief who's come on would really like our team to be 24/7, and we're working through those parameters. Looks like we've got a new comment. So really like the collaboration with police, paramedics, and mental health. Can you talk about any issues of territoriality? I'm really proud of pronouncing that word, and how you were able to work to overcome them. Tash, you might be able to talk about that, or I'm happy to answer that question if you would prefer.
I think you're politically correct. So let's get yours.
So I would say, so I worked mostly crimes against children for the first part of my career as a practicing clinician. So I am a forensic social worker by trade and specialized in children who've been victims or witnesses to violent crime. So as you can imagine, that work is pretty hard, but I'll tell you, doing clinical oversight for this team is harder than that, mostly because of exactly your point. We have a team of incredibly dedicated folks, but everybody has their own kind of sphere in which they, or schema to which they approach the problem. So we had to do some shared mission and vision planning. It did not go well. Tash has been a part of this team from the beginning, and there was a full washover before myself and the sergeant came on because people had different goals in terms of collaborating. I think part of the way that they've been able to overcome that in this community is because they're all under the same organization. It's easy to avoid mission drift. And so, and again, information sharing. And that's also part of why we have this kind of bi-monthly, right? That's every other month, not twice a month, meeting with our community mental health and hospitals. Because frankly, some people don't want law enforcement or teams like this involved in behavioral health, so we have to manage those. So having everybody work under the same roof, I think co-leadership between the sergeant and I, and then treating this as its own kind of NGO with shared mission and vision planning, I think has played a role. And we haven't got it completely sorted out, but we're working on it. And what we care a lot about is hiring the right people, as opposed to just kind of putting bodies in the role.
And we all ride in the same car, so actually we're in the same office, we're in the same car. We are, you know, within 6 feet of each other for 40 hours a week. So we spend a lot of time together. But that also allows us to kind of debrief calls afterwards where it's, you know, it's like, did I overstep anyone? Was that fine? And they're like, no, we totally got that. Or, you know, next time I think just plugging this in this other resource that I didn't think of could be a good thing. We try to like trade off on scene and invite people and have conversations. We'll kind of divide and conquer. If it's a family disturbance, someone will start talking to one part of family, the other will talk to the other. But we all know we're kind of going towards the same goal of, you know, giving some strategies so people can de-escalate themselves and stay calm in those environments. But I think we all do a pretty decent job of debriefing after every call, even some of the really easy ones of, you know, is there something else we could have done? Do you guys agree with that? Do you not? Let's talk about it. So it's very much processing at the moment.
And that's what's important too, is when we do have disagreement, the whole team is willing to talk about that and work through it rather than just, I don't know, compartmentalize and walk away. So.
Well, and we're all really clear. I think part of our interviewing strategy is also sussing out how willing people are able to do that. And where the law enforcement officer has the first say on anybody going in because of the safety model. So we got another question on here. So where and with whom is the M1 client while they are waiting for placement acceptance at a hospital? So we have a case manager who will call and check for beds. And this is a new process for us to be able to overcome the kind of hospital stay. And so what we'll do is we'll try to create safety where we're at. And so we might stay with them in their home as we're looking for beds and determining what that may look like. And so we get some emails from folks every day about how many beds are available so we can hit them up on the way as we're transporting them. But this team is not afraid to stay in the field and keep somebody safe until we can find what that looks like or where they are going. I think if there is a considerable amount of time and the person is deteriorating, then we will just go to the ED for safety. But we want to make sure that people have that discretion. And if we can get them to a bed, we will. So we're going to walk through some of the other programs, but we're going to go through those pretty quickly because Maeve talked about them in the interest of time. Because we've got about 20 minutes. We want to make sure that folks have some time for questions. Does that sound good, team? Okay. All right, then we'll squeeze in here.
So our community health program is run by our paramedics. It is separate from core, but it's run by our core paramedics. So referrals come in from hospitals, from ERs, from like family care offices, all that kind of stuff saying, hey, this person is coming in like a lot. What gaps are we missing? Do they need a primary care doctor? Do they need a specialist? And they're not able to access that. And that's why they're going to the ER, you know, every other week. Do they need medication refills and they can't get in with their doc? And that's why they're going. So our medics really kind of sift through all of that and figure out what resources does this person need and how do we get it to them. We've had our medics end up getting someone a blood glucose monitor because that's what they needed to not have those blood sugar crashes and end up in the ER. We've had them get people, you know, portable oxygen tanks because that's what they needed to be successful in their life and continue doing all the things they're used to. I mean, they're very good at assessing that and providing that resource and that support and things like that to be able to kind of get people out of the ER and being able to be in their homes and, you know, use their resources, use their doctors, things like that. We also have a nurse practitioner who works with the community health team. So she's able to go out and assess, she's able to write, you know, bridge scripts as far as we've had her do it for both psychiatric and for just health concerns. And she's able to kind of say, I can do your wound care for the next 2 days because you're homeless, and getting to the hospital all the way across town is just not feasible. And she's been able to do stuff like that. So we've really kind of built out that team quite a bit, and they do some pretty amazing stuff.
As you can imagine, there's lots of spillover, right, in terms of people taking care of their health and behavioral health and mental health issues. We're really trying to increase people getting connected to primary care, having a medical home. We know that the numbers have shifted substantially, where 20 years ago, the trust you had for your primary care doctor was in the 70 or 80% in terms of, helping you determine life decisions, where now it's down to like 30%. And so part of this team is trying to bridge that gap. I'm going to take this next one. Are you going to keep going?
Yeah.
So this really covers what Maeve already talked about in terms of what these programs look like. And in Longmont, we really leverage Hope Light Medical Clinic. They also have a behavioral health unit, and this is one of the only places that offers Medicaid behavioral health services other than our community health program. And our paramedics will help folks get connected to Salute and Hope Light in order to follow up with their health needs, again, to keep them out. So they're not going to emergency rooms for routine care. So Maeve talked a little bit about
Yeah.
LEAD already. So LEAD, just to reiterate, is our law enforcement assisted diversion, and it is a peer intensive case management model. So all of the case managers have shared lived experiences. Typically, LEAD is a case manager for folks struggling with substance use or abuse, and so they will engage with them in order to work forward. Again, as she mentioned, it's a harm reduction model. We just engaged a clinical crisis or a clinical case manager. So we now have a case manager to help with core cases, specifically to try to remove some of the case management that occurs through core workers. As Maeve said, they do quite a bit of follow-up with folks to be able to offer kind of short-term treatment through the case management to get people on their feet. Anything I missed?
I don't think so. I mean, if we're able to, the kind of beauty of having a clinical case manager on the LEAD side is that if we start with a skill, a breathing exercise, a de-escalation technique, something someone can do to kind of ground themselves next time when the case manager follows up, they're able to practice those skills to remind people of those, to do them with them. And that's something we haven't had before we had this clinical case manager position. So they're really able to carry on a lot of the stuff that we do in that in-moment crisis to help out and do that other times as well.
Awesome. So the last thing is the Angel Initiative. Do you want to talk about that now that you're back, Touch? What's up with Angel?
Sure. I mean, Angel's pretty basic. I mean, the nuts and bolts of it are anybody at any time can walk into the lobby of the police department and ask for help, ask to be in the Angel Initiative. And they will, if there's not a case manager available in that moment, the case manager will connect with them later, and they will go ahead and take their information, do a psychosocial assessment with them, determine what is the appropriate program for them, and then find a bed and a pathway to get them there. And then it's changed a little bit, but essentially PD officers or fire department trade off when they do it if there's not a case manager available.
Awesome.
Yeah.
So the last thing we're going to go over, and then we'll give you an opportunity if folks have more questions. We appreciate people plugging them into the Q&A, is we did a mixed methods empirical program evaluation. So we received some money from CCTSI, and we did a community-based participatory research where this team really determined the information they wanted to know. And so we did an acceptability of core by interviewing peace officers, which just means police officers in the state of Colorado. But we interviewed peace officers within the Longmont Department of Public Safety with a 4-item measure, and you can see the questions in there. But the sexiest part of the data was we are the only program in the country who actually have interviewed people who received the service. And so one of the things that I'm really interested in as a researcher is understanding what the people in the field who are receiving this service, how they feel about it and what that looks like. And so CORE determined the questions that we were going to ask the folks in terms of what they wanted to know in terms of the service delivery that they're offering. You can see the sample of those. And the questions they really wanted to know was, did you know we were there to help? Did we scaffold skills and provide resources in the moment? And what was the appropriateness of our follow-up? So we did a deductive analysis where we coded to those questions and an interpretive phenomenological analysis, which allowed us to go up and down, inductive and deductive as other codes kind of came to the surface. Another goal of this was to be able to really quantify or operationalize is actually a better word, what the intervention is. Because if you look at any of the literature across the globe of what co-response is, we don't really know what is being offered on the street except for kind of diversion, or the co-response model is the intervention. And so I really wanted to be able to get some data out there about what does that look like. So spoiler alert, CORE is acceptable to the peace officers. It was an easy kind of question there. It was acceptable. They like it. It works from there. The qualitative findings really simply were broken down to kind of feedback that they had for CORE. And some of that feedback, all of it was really positive, but they wanted 24/7 access because they can't control behavioral health crises. That came from parents who have kids who really struggle, as well as folks who are struggling in general. Just organically, people talked about, without even being asked, the difference between a CORE response versus a patrol response. And I don't think anybody on this team is surprised by that. I think it's pretty widely known that patrol officers are asked to manage things far outside of their scope. And so this allows teams like this to be able to come in and offer services and complex problem solving skills differently, where patrol is just trying to get back into service, which is their job. As one of the questions around helpfulness and how they were treated, almost all of the samples. So we ended up doing 23 qualitative interviews, in-depth qualitative interviews with folks. And they talked about, one person talked about how knowing CORE is here helps them feel like they're really a part of a community. I think we have quite a few qualitative data that really supports that 21st century policing, which came out in Obama's administration, as well as this being a model of what true community policing looks like. People felt like they were treated with respect and kindness. They felt like CORE was there to understand as opposed to just fix. And so they didn't feel like they were on a conveyor belt where somebody was going to kind of slap them with an M1 and move them on. As we talked about a little bit earlier, follow-up is where everything is at. We have a quote from a participant who said, they came back, like they didn't forget about me. Like they came back, they didn't have like the book. Like, so we have a mindful self-compassion book. We have a DBT book. We have books for young kids or young people around anxiety, depression, aggression, stuff like that. And Maeve actually was on a call with one of our officers, and they didn't have the book in the car, and they came back and brought it. And this participant was blown away that they didn't forget about me, that I wasn't just a check in the box. It wasn't just them doing their job. And then resources, my favorite quote from the resources category, where we coded where people gave feedback about what kind of resources they wanted. This is where they said they really liked the fidgets, the books, all of that. But one lady, I giggled when I coded, where she said, they kept telling me, if you need anything, let me know. And she goes, but I don't know what that means. I don't know if that means $1 million. I don't know if that means a bus pass. I don't know if that means a new car. And so some of those things are just really easy to be able to make sure that we really are concrete about the resources we can offer so people know how to use us. So we appreciate your time today as we share the work that we love to do. You have Maeve's contact information, Tash, and mine is at the bottom. You're welcome to reach out to us at any time if you have concerns for folks in the city of Longmont that you'd like us to follow up on, or if you're just curious about our programming.
Thank you so much. I think this was an excellent presentation and it really exemplifies what we're hoping to disseminate, which is evidence-based practice solutions. And just it's so wonderful to see a multidisciplinary solution to, as you said, a complex problem, and taking this prevention approach for like sustainable long-term change in these people's lives. Real quick before I use the last few minutes facilitating some Q&A, we did have a question about willingness to share slides. If someone contacts you, are you willing to share PowerPoint slides?
Yeah. Josh,
Great.
feel good about that?
Thanks. Wonderful.
Yeah, we're happy to do that. We're happy to do that.
Well, I want to, I'll keep my eye on the Q&A, but I want to pick up on that line of questioning about territory, issues that may have come up, and follow up on that. And, this to me seems like such a no-brainer, this harm reduction approach. But, as I know in the real world, just because something seems like it makes sense doesn't mean it's easy. And I was wondering if you could share a little bit more about any kind of barriers or challenges that came with setting up this program, kind of like lessons learned, if there are other, municipalities or just jurisdictions that would be looking to start this, kind of some of the challenges you had to overcome to make this successful. And you hinted at it with the HIPAA, reference, like there's probably just some really in the weeds details that people wouldn't have anticipated would be challenges.
I think some of the really big things are just finding the right people that are in it for the right reasons, right? Previously, we had some folks that really didn't, I think, believe in the way the program was designed, and worked against it rather than accepting that it was truly everybody on the team had their heart in it, really cared for the community, and wanted to do good stuff. And it didn't work with those individuals. And as we've grown as a team, I think we all have the same vision and recognize that some things that are uncomfortable for police officers to do on these calls, or clinicians or paramedics, we recognize that we're working towards helping people. And even though it's outside of what we'd normally do, it's very effective and helpful.
I think to Tasha's point, I cannot emphasize enough the shared mission and vision, because while Tash and I may have the same vision, our ethics and what we've trained on how to get there are going to be different, right? I think good leadership models where we want them to make mistakes, and that's okay. We want them to be able to kind of rough and tumble through some of this. And we still have things we have to get through, right? Our clinicians, when somebody gets cuffed or arrested, feel like they failed, right? And that's not the case. And so having to really understand the different cultures and what folks are supposed to do, and that communication. And it's part of that screening on the front end. So Tash was really kind in talking about the previous clinicians, but their goal was to change police culture, and that wasn't the job that they were hired to do, right? We believe a lot in the ripple effect in terms of Tash is everybody's #1 fan, and he's the longest running cop on this team. And the people on the street prefer him to all of us on any day and any week. And he has a gun and a badge. And so I think we really push people outside of these false dichotomies. But if people aren't open to thinking about that and understanding that you have to get a little bit comfortable being uncomfortable, this is probably not the place for you. I'll tell you as a social work scholar, and that I come up against it quite a bit, because there's a lot of abolitionists in social work practice. So I engage in that conversation quite a bit around some of those types of things when it comes to police brutality and kind of how that shows up. And so that, I think, would be the biggest point of contention right now. And I think that folks like Tash and our other officers, Gina and John, who are out there doing everything they can, and the contention also because community mental health calls them, right? Like community mental health calls law enforcement to help all the time. So there's some things that happen on the street that aren't widely known that they have to answer to, which makes things pretty difficult sometimes. Sarah?
Thank you.
Yeah.
We have 2 more questions, and I bet we can squeeze these in. The first is from Jessica. Do you have future plans for more evaluation? Or maybe any plans for the future? You talked about going 24/7, what's next?
Yeah, so I think we'd love to do additional evaluation. And actually one of the things that we've got to fund this work, right? So I think that for our research team, one of the things that we're up against is investing in programming, but don't have funding built out for empirical research. Everybody has an evaluation component, but evaluation as part of program grants is not as robust or as rigorous as evaluation, which is why we went through an IRB process for this, as opposed to not having to do that. We would like to continue to interview folks. We also want to know our impact. So the impetus to some of these teams were to reduce time in the field, which and calls for service. But the truth is as people build relationships with you, and when you have a lovable Tash on your team and a Maeve, they call you more. And so reducing calls for service is not a great benchmark to reflect how well you're doing. And also to reduce hospital stays. So we are looking to maybe move to the next step of interviewing and collecting data from our kind of our drop points to see what about the criteria of people on M1s? Are people presenting any different than kind of your run-of-the-mill patrol M1? We're curious about regional accountable entities and how we're helping them reach their key performance indicators, right? Because they are part of our kind of bi-monthly meeting in terms of reaching their goals specifically for Medicaid folks. So that's some of the ideas we have for future research. We're currently writing a grant right now in partnership with Michelle West and her PEAKS team, who are all experts in early identification of psychosis, to be able to get our school resource officers here trained in early identification. And then we want core to be even more deeply trained so they can problem solve in the field and get people where they need to go, particularly around psychosis. So we're hopeful to get that.
Great. And just in the minute left, the last question is about when there's other individuals present, like a family member or a partner, and if you run into issues handling like a mix of issues, domestic violence, partner violence, interpersonal violence, and how you manage that.
So kind of like I talked about a little bit before, we like to divide and conquer, but we also know if we're leaving someone on scene, like they're still going to be in their house, they're going to be in their community with their neighbors and their families and all that type of stuff. So we do a lot of work with parents, with spouses, with friends, with their doctors, all that kind of stuff to make sure that whatever approach we're trying to put in place for the individual is supported by all. So we give a ton of education to parents about managing kids with discipline issues, with school issues, with suicidal thoughts. We give a ton of information to other people. I think with some of the domestic violence type stuff, because we have officers on the team, if I'm not trained specifically in domestic violence, I don't know what is, what isn't. I've been learning a lot about that over the past 2 years, but our officers are able to kind of pick that stuff up and be like, let's build this relationship so that this person is comfortable talking with police, with people about this stuff. And then let's get patrol in here to, take that report to do what they need to do on the kind of law side of it. But
our team doesn't look, I think our officers are also really great in terms of they don't look to kick it. So if a criminal aspect shows up, they have some discretion in terms of what to loop in and what the primary is, but it's not a perfect science, as you all know. Anything that has to do with humans isn't. But if there's something showing up and we can see it's a primary behavioral health, they're not looking to issue summons. They're not looking to get folks in trouble. They're trying to get people connected and to bridge that relationship. Right, Josh?
Our officers try very, very hard not to handcuff people, even if when we got there, they were aggressive, they were agitated, all that. We put in all the work between all the professions to not have to do that. And our officers, I know it makes patrol a little uncomfortable when it sees our officers, not cuffing those people, but Tash and Gina and John have all put in the work to gain that trust, to gain, that kind of relationship where they don't need to cuff this person. And that usually shows people a lot. That really helps kind of differentiate us from patrol is when patrol takes someone on M1, typically they're handcuffed, or when we do it, we're not. So I think that really comes to the fact that we're not trying to be punitive. We don't want that. We want to be different from patrol. So a lot of our practices are very different in that way.
Let's see.
But safe.
Let's say.
Yeah, well, I do see the time and some people may have things to attend next. So I just want to officially close this webinar and thank you again so much. And thanks for the discussion. This has been very informative and it makes me feel optimistic. So I want to thank you again.
Well, people are welcome to email with additional questions. We're so grateful for the time. Trust, I think, is the underlying factor of the success of this team around safety and otherwise. And thank you. We wish you well.
Thanks. And Ashley will close the webinar for us.